دكتور كدرو.
Thank you very much for the nice introduction. Ladies and gentlemen, Mr. Chairman, let me first thank the organizing committee for the nice invitation, and please let me congratulate the Emirate Cardiac Society and the whole administrative and scientific members of the Emirate Cardiac Society for really discussing all those new things. Last year we discussed in detail the cardio-oncology, this year women and heart disease, and by the end of the year there is a special meeting for cardio-obstetrics. And probably next year, I'm sure there will be cardiodiabetology and cardiolipidology and cardioimmunology. Anyway, so what are we talking about? Let's assume that we have this young lady. She's 28-year-old, and she played tennis in college, and she has normal left ventricular systolic function ejection fraction of 60, but she has bicuspid aortic valve with maximum velocity of 4.3, so the mean gradient is 42 millimeter of mercury, and she recently married, and the common question, can I get pregnant? And with that, we'll try to cover some of the points. Where there is no time to cover all the valvular disease during pregnancy, but we'll discuss about preconception evaluation of women with aortic stenosis and the valve choice in women considering pregnancy, and anticoagulation for mechanical valve, and we'll touch up on some counseling. So if we have a lady with bicuspid aortic valve and stenosis, there are many options to treat, and every option has its own price. We can discourage pregnancy, and either we get this appointed woman or disobedient woman that she'll say, I'll not agree with that, and she'll go ahead with pregnancy. Or we can encourage the pregnancy, and we'll say, just go ahead and get pregnant, and there is a risk to the patient. There is preconception aortic valve replacement, but even if we get the bioprosthetic valve, there is increased incidence of valve degeneration. And even if we consider aortic valve with mechanical valve replacement, there is this risk of thrombosis and the fatal risk to the fetus. So preconception, the best procedure is Ross procedure, well, the surgical, but that's need appropriate center and appropriate time and the right surgeon. So what are the right choice? We know during pregnancy there is increase, let me just, here, okay, good. Increased stroke volume that happen, okay. So increased stroke volume. Here, is it working? Yeah. Stroke volume, that's due to increased plasma volume, and there is relative anemia, but that's happened at the first trimester, and that's plateau in the second trimester, and continue till the end of the third trimester. And with that, there's significant increase in cardiac output, and with that, there is the gradient across any stenotic valve will increase, even if there is no change in the valve area. And this study showing that even if the patient starts with the moderate case of aortic stenosis with a gradient of 20, okay, so that's much better. If we start with a gradient of 20, she will reach increase in the gradient around 30 to 40 and even 50%. So the lady moves from moderate stenosis to severe aortic stenosis. So how can we assess the risk of for the mother and assess the risk of the pregnancy on that case? So there are three registries. I'm sure everybody knows about that. There's the HARA registry, the CARPREG registry, and the World Health Organization risk group. The World Health Organization is just a consensus of expert opinion that classify the disease into 4 categories, which is grade 1 with low category like minor arrhythmia or corrected ASD and VSD, and the high risk was grade 4, that's mean severe heart failure or pulmonary hypertension. And the Carbraek and Zahara are a really prospective registry that got significant amount of pregnancy and followed them, and from that they got some criteria to assess whether this pregnancy is a high risk or low risk. And for all of this, the definition, severe maternal aortic stenosis is considered a high risk situation. But with that, how high is that the risk, we don't know. So we need more data. The ROPAC registry that's done more prospectively and followed women from 2007 and followed that in multiple centers and in multiple countries, 60 countries, and avoid any recall bias and report publication bias. And from that, there were 96 women in that registry with moderate to severe aortic stenosis and prior pregnancy. 62 of them had moderate aortic stenosis, but 34 of them had severe aortic stenosis with peak gradient 89 millimeter of mercury. 96% of them were in NIHA class 1 to 2%, and all of them had normal ejection fraction. And look at the result. Maternal mortality 0, whether in all the cohort or in moderate aortic stenosis or severe aortic stenosis. That's a good thing. But look at the other thing. That's the mortality. But the morbidity, there is increased cardiac admission, increased heart failure, increased preterm death, preterm birth, sorry. And whenever we go to severe aortic stenosis, there is increased maternal admission more than a third, increased heart failure in about a fifth, and preterm birth more than a third. So, and with that, they came with this recommendation: if there is the severe aortic stenosis, but the Vmax is less than 4 millimeter per second, that's mean, that's mean the peak gradient is less than 64, and the patient is asymptomatic, you can go ahead and tell her that she probably pregnancy is safe. And if there is the Vmax is more than 4 meter per second and the peak gradient is more than 64, we need further assessment, whether by exercise test or assessing the left ventricular function and check the BMP. And if that abnormal, we recommend against pregnancy. And if the study is normal, we can say go ahead with pregnancy. Now, if the Vmax is still severe and the patient is symptomatic, we don't have any option except for medical therapy, probably balloon valvuloplasty for the aortic valve, or probably aortic valve replacement during the pregnancy. It has been reported. I don't know whether TAVR has been reported during pregnancy. To my knowledge, I haven't read anything. If anyone knows about any cases. So, and if the patient is asymptomatic, we can proceed with pregnancy. So everybody got, at that time, I remember that was 2016, I got a lot of email, that's European Society of Cardiology, and that meeting that there is 0% of mortality, deaths for pregnant women with severe aortic stenosis. But all of that, forget about that. There is all those case reports. That's one case of woman died with aortic stenosis shortly after delivery, another 24-year-old woman with sudden death in the 3rd trimester, another case of 23-year-old woman died postpartum. So there is not as safe, and we cannot say 0% mortality, but we agree that aortic stenosis is high risk for pregnancy, and those are the options. So for our patient, she did receive aortic valve replacement and asymptomatic, and either before recommending the aortic valve replacement, the exercise test, and BMP, if that's normal, that's okay to proceed with pregnancy, but this was abnormal, so we recommended against pregnancy, and she had the aortic valve replaced. Now, how can we get aortic valve? Is that with bioprosthetic valve or mechanical valve. We know the bioprosthetic valve restores hemodynamics and there is no need for anticoagulation. However, there is increased incidence of valve degeneration in younger patients, and pregnancy may accelerate the valve degeneration, and the patient may need repeat sternotomy. So this is a study showing that if you get bioprosthetic valve and at the age before 60, there is increased degeneration compared to the bioprosthetic valve when you get that after the age of 60. So, and probably pregnancy may accelerate the valve degeneration. That's some of the theories about that. So, shall we get a mechanical valve for that? If we get a mechanical valve, there is increased valve thrombosis, there is increased embolic complication, there is increased risk of hemorrhage due to anticoagulation. And for the baby, there is increased risk of miscarriage, increased risk of fetal demise, and teratogenic effect because of the anticoagulation. And just remember, pregnancy is a hypercoagulable state. Look at this blood test level. Some of the factor 7, 10 times above normal, 10 times the normal. And the other factor, and the anti-thrombotic effect of the protein S and protein C, that's decreased. So we have double increased risk of coagulation activity and 5 times increased risk of thrombosis and DVT and PE. So again, for the ROPEC registry, they followed the patient with mechanical valve. And all the results are really encouraging. Cardiac hospitalization, 23%, major hemorrhage, 15%, and valve thrombosis, 5%, stroke, 1.5%. And for the baby, a lot of bad things. Miscarriage, 16%, fatal demise, well, that's mean this of the fetus before the 24 weeks is 3%, preterm birth, 18%, and congenital anomalies, more than 5%. So with that, mechanical valve has a total of maternal mortality 1.4 and major event 24%. Remember, that's only over a period of 9 months of pregnancy. We are not talking about a long-term period. This is happening just over a period of 9 months of pregnancy. So what's the conventional wisdom? That to avoid mechanical valve when planning pregnancy, but how can we help now a woman who already got a mechanical valve and she want to get pregnant, or if we are receiving this woman in our clinic that she has a mechanical valve and already pregnant. And we agree during that period, uninterrupted effective anticoagulation is required throughout pregnancy in women with mechanical heart valve. Keeping in mind that the incidence of adverse event, and that's warfarin embryopathy, that's risk happen between 6 and 12 weeks and cause deformity and mid-face hypoplasia, short limbs, anticoagulated fetus, and possible effect on the intellectual impairment in the fetus. So with that, let's review what's the best way. If we now discuss the first trimester, second trimester, and third trimester, we can use heparin all over. We know heparin, if we prefer for the safety for the baby, heparin doesn't cross the placenta, and we can use it in all the trimester, or we can use heparin in the first trimester and then switch to warfarin, or we can use warfarin in all trimester, and just before delivery, we switch to IV heparin. So with that, this is a study between, collected the cases between 1966 and 1997, over 30 years, and was published in the year 2000. Following more than 1,200 pregnancies, there were, but most of those valves, look at that, is 50% ball in cage valve. That's the old version. And 66% were mitral valve, and the maternal mortality was 3%. But look at the bad effect. For heparin, maternal death is 7%, compared to warfarin is 2%. Thrombosis with heparin, thromboembolism 33% compared to 4% with warfarin. But congenital or effect on the baby, with heparin, no effect on the baby, 0%, but with warfarin is 6%. Okay, so with that, we got the pregnancy with a mechanical valve is very high risk, and unfractionated heparin throughout pregnancy has an acceptable maternal outcome, and warfarin is associated with poor outcome. So how can we reach that? So this is happened in 1960, as I showed you. But in 1960, we were using this ball valve, and now we're switching to this bileaflet valve. We were using unfractionated heparin, and now we are using the low molecular weight heparin, which is easy to take and dose adjusted. And there were changes in the bad direction since 1960. This was the music and the people that they used to wear, and this kind of music and the wear that people that are wearing this year. Okay, so we need contemporary review. So this contemporary review from the University in Washington in Seattle compared the contemporary anticoagulation strategies. And they did a really good literature review. I'm not going to go through that. But from 825 paper, they finally reached only 18 paper because they excluded the papers that use the ball cage valve, which is a very old valve, and the small series, and which reported the side effect. So with that, they came with that finding. The first trimester, second trimester, and the third trimester. And we have the option of giving warfarin throughout, and that's subdivided whether the dose of warfarin less than 5 milligram or more than 5 milligram. And then the dose adjusted low molecular weight heparin throughout the pregnancy. And the other one is to start with low molecular weight heparin in the first trimester and switch to warfarin. And the other one to use the unfractionated fractionated heparin in the first trimester and switch to warfarin later. And with that, let's review what we get. Okay, now with that, this is the effect of the mother. So with vitamin K, the best result we got was 5% incidence of maternal problem, 5%. And it's much higher when we use the unfractionated heparin, even if we switch to vitamin K in the later trimester. Now, for the risk for the baby is reversed. When we use vitamin K, increased risk of the baby up to 35%. And again, even if when we use unfractionated heparin. So, and this is in general, when we combined all of them. So this is the meta-analysis, and this is another meta-analysis published from Europe and giving the same idea. When you use warfarin, less mortality for the mother, and when you use low molecular weight heparin, higher for the mother, and the reverse is for the baby. So now, why is that? Why is low molecular weight heparin is not working and giving us bad effect? And remember the idea that pregnancy is increased hypercoagulable state. And this is the group from University of Southern California. Just 1 minute. The Yuri Al-Kayam, they are reporting that if you need to use low molecular weight heparin, you need to monitor your anti-factor 10A level. And this is if you monitor that, if you give that would get this level at peak, still more than 70% your trough is subtherapeutic. Even if this recommended dose of 1 to 1.2, still 50% of the cases are still subtherapeutic. So if you need to get therapeutic level, you need to get the level of anti-factor 10A more than 1.2. And really hardly any center is following that, and it is difficult to follow that. So with that, we came to this idea. If you use low molecular weight heparin, you need to monitor factor 10A. We even with now with low dose warfarin of 5 milligram, less than 5 milligram, the incidence is much low complication for the fetus or the mother, but still is not zero, and there are reported cases of fatal impairment even with low dose. With that, we are, Mr. Chairman, in complete confusion, so we need to, to address case by case and get counseling in order to lead our pregnant patient to the right decision. Thank you very much.